Hi, my name's Dr. Don Buford. I'm an orthopedic surgeon in Dallas, Texas. I'm very honored to be able to participate in this 88th annual meeting of the Western Orthopedic Association. Southern Cal is near and dear to my heart. I grew up in Los Angeles, went to high school in North Hollywood, and went to UCLA Medical School. So this is kind of a coming home for me. Thank you. I'm going to talk about stem cells for knee osteoarthritis in this 10-minute presentation. These are my disclosures. They haven't changed significantly since January of 2024. This is a link to the handout. If you go to any browser, you can type in buford.info/WOA 2024, and that will get you a handout to this presentation. To be clear, as of today, there is no peer-reviewed, proven injectable biologic that can regenerate significant hyaline cartilage, correct joint alignment, remove osteophytes, or heal a discrete chondral lesion by itself. However, there are several injectable biologics that can minimize clinical symptoms from cartilage lesions and minimize or stop cartilage loss. Furthermore, they can also delay or eliminate the need for joint replacement, such as total knee replacement. So we need to have these options available to patients in a thoughtful, ethical, unbiased way. Why do we need these options? Well, for starters, the lifetime total knee replacement risk is 7%. 50% of adults diagnosed with knee OA get a total knee replacement in the United States. That's above the world average. We now have about 11,000 people a day turning 65. So this need and this population is only going to grow. According to this article in JBJS, the 30-day mortality is relatively low at 0.18%, but the 30-day complication rate is relatively high at 5.6%. So if we have safe alternatives, it's worth exploring. And this chart really sums up nicely the risk of revision surgery based on the age of the index total knee replacement. You can see here, the red is added by myself. There's a 20% chance of revision knee replacement if the initial knee replacement is done when the patient is 55 to 59 years old. That's a significant 1 out of 5 patients that's going to need a second surgery if we're putting in total knees before they're 60 years old. We need to have other options that may carry patients 5 years, 10 years, even 15 years, as long as they get a good clinical outcome. The risk of arthroplasty infection, admittedly a catastrophic complication, is 1.5% on average. Infection is the leading cause of reoperation in total knee replacements. I'm going to focus on just the FDA compliant quote-unquote stem cell injection. I'm going to talk first about Adipose. This is a level 1 study from 2022 that compared the lipogems microfat technique versus PRP. This study had 2-year follow-up. They did a reasonable job telling us how much blood they drew to make PRP, but then the quantification sort of fell apart. What they found was that both of these interventions worked for about 2 years and that there were no significant differences in outcomes between the lipogems adipose procedure and the platelet-rich plasma procedure. They did note that patients with higher grade osteoarthritis did better earlier with the microfat, but the results seemed to equalize by 6 months to 1 year post-procedure. Here's another study based on microfat. This was a 2024 study just published this year. This is a level 2 randomized controlled trial. In this study, they did a better job quantifying the platelet dose at 15 billion, which would be considered high dose PRP. You can notice the N is pretty small, 23 in the PRP group, 26 in the lipogems group. They followed patients for just a year. And in this study, they found no significant difference between treatments. And so once again, another study with 2 different orthobiologics, essentially the same outcome at 1 year. So whether they followed patients for too short of a time to show a difference, or whether the patients in this population under study didn't have enough clinical difference to matter between these 2 treatments, it's a little bit unclear. But the bottom line is, based on this study, it's hard to make a clinical change. So let's talk about bone marrow aspirate. There's really only one device that's got a 510(k) approval for this. This is the so-called Marrow Solutions needle. In this study, they reported on 262 knees, so a very large N. Unfortunately, they only followed patients for 6 months, so a little bit hard to extrapolate any significant clinical data from a 6-month follow-up study in this type of patient population. This was retrospective and primarily just looking at pain scores. They did conclude that 71% of the patients reported better pain scores at 6 months, and that 61% reported better WOMAC scores at 6 months, and with minimal complications. So we have much more robust literature looking at bone marrow concentrate used for knee osteoarthritis. This is a level 1 study published in 2020 from the clinic of Philippe Hernegal in Paris. This is a study with 15-year follow-up trying to compare patients who received intraosseous BMC versus patients who received intraarticular BMC. So several important things to point out here. First of all, it was well-powered with 60 patients in each group. Second of all is look at how much bone marrow aspirate Philippe drew. He drew 155 cc's of bone marrow aspirate. He then centrifuged down to 40 cc's of bone marrow concentrate and then used 20 cc's for each knee. One knee got an intraarticular injection. The other knee got 2 separate intraosseous injections, one in the distal femur, one in the proximal tibia. Both groups had significant pain relief in this study. The intraarticular group had pain relief that maxed out at 1 year and was not significant at the 2-year mark. However, the subchondral group still had significant pain relief at 2 years, which seemed to tilt the needle towards subchondral or intraosseous injections being the better location for bone marrow concentrate for knee osteoarthritis. Furthermore, the intraarticular group had a decrease in medial compartment cartilage volume at the 2-year mark, and 18% of the patients that had an intraarticular injection increased by 1 KL grade over the 2-year time frame. Contrast this with the subchondral group that didn't have a decrease in cartilage volume. They had an increase, a 2.1% increase in medial compartment cartilage volume. And then finally, the intraarticular group had a 4.6 per year progression to knee replacement, such that at 7 years, 45% of the knees had received knee replacement. Contrast this with the subchondral injection group that only had a 1.3% per year progression to knee replacement at an average of 14 years, so twice as long. And even at 14 years, only 20% of the knees had conversion to total knee replacement. I want to talk about 2 recent 2024 papers that were published. The Indian orthopedists seem to be looking now at dosing for bone marrow concentrate for intraarticular injections, and they're coming up with some really interesting data. In this first study, there were 3 groups. All patients had KL1 or KL2 knee osteoarthritis, and then they were given 3 different total cellular doses. Now, these are not MSC counts. These are like total nucleated cell counts. So there's more in this count than just MSCs. In the first group, they got a dose of 10 million cells. In the second group, 50 million cells. And in the third group, 100 million cells. After 1 year follow-up, what the authors found was that the VAS scores were down 5 points on average in all 3 groups. And this was the same across all 3 groups. The dosing didn't seem to matter. And so in real terms, that means your patient comes in with an average score of 6, and in 1 year, their average VAS score is only 1. And for most patients, this was significant. I say very significant reduction in pain. The KU scores also went up in a mirrored way. This study, also published in the Indian Journal of Orthopedics this year, was a slightly different bend. In this study, there were 4 groups. They were based on cellular dosing, but the cells were dosed per kilogram body weight. So in the first group, patients got 1 million cells per kilogram. In the second group, patients got 2 million cells per kilogram. In the third group, 5 million cells per kilogram. That was the high dose group. And in the fourth group, it was a normal saline placebo control group. At the 1 year follow-up mark, patients in the higher dose groups B and C, had VAS scores down 60%, which was highly statistically significant. And in addition, their KU scores were up almost 100%. They had just about doubled. And so this was a very significant change, positive change, in these patients' clinical status at 1 year. So the lowest dose that seemed to give this effect was at the 2 million cells per kilogram. So if you've got an 80 kilogram man or woman, you're looking at 160 million total nucleated cell count to get this result. So how do I manage this? I present the most recent evidence, the highest level evidence based on the orthobiologics that are regulatory compliant. And I present this along with other non-surgical and surgical treatment options to my patients with knee OA that's symptomatic. This is an open, often lengthy discussion and includes cost, and it includes the FDA status when appropriate. I do not use any allograft injectable products because none are approved for any specific human indications in the United States as of the time of this recording. I appreciate the chance to participate, and hopefully we can have chats online at these social media outlets or at the next big meeting where we can get in touch. Thank you very much.